Hello, I'm Clayton Smith. I'm a radiation oncologist at Ochsner who specializes in treatment of CNS malignancies. I'm the co-director of our Gamma Knife program and also our department's quality and safety director. So first I wanted to go over what radiation involves because I wasn't sure the audience how much exposure people have had to radiation in the past. So I see the patient for an initial visit and kind of look at their history and all of their imaging and pathology and then make a recommendation as to whether radiation might benefit them or not. If I do make that recommendation, then the next step is setting them up for the radiation treatment. We perform what's called a simulation, where in the case of brain, and this pointer's not going to work very well, in the bottom right, that's sort of a flat sheet of plastic that when it gets warmed up gets flexible and shapes to the patient's face, which you see in the picture just above that. So each day when the patient comes for treatment, that mask is put on their face and it helps to keep their head still while the machine delivers the radiation. The treatments take about 10 minutes a day, so they're very quick. And for most tumors, it's going to be Monday through Friday, usually in the case of glioblastoma for about 6 weeks. So this is an example of a radiation treatment plan for glioblastoma, which is something most people don't see what our plans look like, but this is sort of my equivalent of what the surgeon does in the OR. So for glioblastoma in particular, we target the high-risk area around the cavity, and that gets treated to a higher dose, to about 60 gray. And then because there's risk for microscopic spread of disease, we treat to a slightly lower dose to that surrounding, and that's what that green volume is. With modern techniques, we're usually treating in arcs, so the bottom right corner is actually kind of the arcs that the machine moves through to spread out that dose and try to make it precise to the tumor bed. This is our machine, actually. It's not an example of the machine. This is what's called a linear accelerator. So this is what generates the x-rays that treats the patient. So that black table in front is what the patient lays on. The mask goes over their face and it helps to keep them still, and then that machine will actually turn around them. With modern technology, we're actually able to do a CT scan and make sure that everything is lined up appropriately so we know that we're treating the right area. Side effects of radiation are divided into short-term and long-term, and they're all related to where we're treating. So in the case of the brain, most common side effect is going to be fatigue. You can have focal or whole hair loss depending on the size of the radiation field. With modern techniques, we get some dermatitis towards the end, meaning some itching and maybe a little redness, but it's not usually what most people associate with radiation burns. And then radiation can cause inflammation of the brain tissue. So sometimes this mimics the initial symptoms that the patient had when they presented with their tumor. When that develops, we treat that with the steroid to calm down the inflammation. Longer term side effects can have sometimes profound effects on cognition, usually due to short-term memory impairments. So I usually tell patients you may find that if you have a list of things you want to get at the store, by the time you get to the store, the list has left your head. But it's not like Alzheimer's, so you don't forget people you know or things from your past. So why do we treat with radiation for these tumors? Well, there were some studies done by neurosurgeons back in the 80s that looked at this flare sequence that Caroline was describing in her presentation. And after they had resected the contrast-enhancing tumor, they did biopsies of that flare area and actually found that there were microscopic tumor cells there. So we know that even if the surgeon gets everything that he can see and that we see on the scans, there's still some surrounding tissue with at least microscopic disease left over. So radiation primarily accomplishes its effect on the tumor by damaging DNA. Some of that is directly when the x-rays are delivered, they actually break the DNA. The majority is that they split water molecules and create free radicals that then damage the DNA. Most of the damage doesn't occur during the actual treatment. It actually occurs in the days and weeks after as the cells go to divide because the DNA is broken. They don't have the information they need, and that's actually when they die off. So how we treat has really evolved over the decades, and mostly due to our technology. So some early studies that were done back in the 70s actually gave whole brain radiation to 60 gray, which is something unheard of today. But that's how these were treated. So one of the early trials looked at an older type of chemotherapy versus radiation versus combining with the chemotherapy or just best supportive care. And both of the arms, whether they got chemo or not, but both of the arms with the radiation had the longest median overall survival at 8 months. So a slightly later study looked at a different type of chemotherapy, again with radiation versus best supportive care. And again, the treatments that had the radiation had the longer survival compared with chemotherapy alone or best supportive care. This was also to the whole brain. So one of the questions that came about was, do we actually have to treat the whole brain? Could we just narrow that field down a little better? And so this brain tumor cooperative group trial looked at several different things. One of them was different chemotherapy regimens that didn't really have an impact which type of chemotherapy was given. But the other was giving a portion of the treatment with whole brain, but then a portion where they coned down to just a small area around the tumor versus doing the whole treatment to the whole brain. And there was no difference. So since then, we've sort of figured out that we can reduce our fields to smaller and smaller areas because 90% of the recurrences recur within that high dose region. So a common question I get from patients is, can I treat them with Gamma knife? And if you go back and kind of think about how this microscopic disease is around there, Gamma knife is a very focused form of radiation. And so based on that alone, it wouldn't adequately treat it, but we have actually tested it. So one of our radiation therapy oncology group trials looked at our standard treatment with radiation with standard external beam to 30 gray, and then comparing that with treating that dose, but also giving a boost with Gamma knife, so giving a much higher dose to the area where the tumor is, and there was no difference in overall survival. So we've sort of worked out, at least with current technology, the optimal dose that helps to control the tumor without adding extra side effects. So as Dr. Golden mentioned, our standard now is surgery followed by chemotherapy and radiation, typically for 6 weeks, and then followed by maintenance chemotherapy plus or minus the tumor treating fields. So these are both trials that she went over. So this is that STOOP trial. So this is the one that's about 20 years old and honestly what most patients get these days. And then this is the trial demonstrating the benefit of upfront Optune when you start with that maintenance treatment. One thing I will point out is that patients who have this MGMT promoter hypermethylation present, we know respond better to these treatments, and so their survival is actually better. And so for those patients on this particular trial, if they got radiation and chemotherapy and used the tumor treating fields, the median survival was approaching 3 years. So actually quite a good response when you have that marker. So as you can imagine, this tumor occurs in a lot of older people. And so 6 weeks of coming back and forth for radiation treatments can be pretty involved. And so we've actually looked at, are there ways we can tailor our treatments to the patient, to the population, and figure out, can we get in some dose to help, but not put so much of a burden on them for the treatments. And so I usually go through this with my elderly patients, where we start with what's the most aggressive, and that's the standard of care for 6 weeks with chemotherapy and radiation. And then looking at, okay, well, maybe we can look at condensing that to 3 weeks, maybe to 1 week, and I'll kind of go over some of the data that supports doing that. So this trial looked at elderly patients over 70 years of age, and they were, to be enrolled in the trial, they were deemed not candidates for standard of care. And so obviously, the trial with 6 weeks of chemotherapy and radiation are sort of your best performers. So looking at this sort of poorer performance status, older patient population, we looked at, can we condense that radiation dose into 3 weeks, also give the same chemotherapy, and will they tolerate that just as well? And what we found is, again, the combination is still better than radiation alone. And then the average survival there for the combination is about 9 months. Again, I want to point out that it's not a one-to-one comparison with the prior standard of care trial because those patients at baseline were much better functioning than these patients. Again, patients with that MGMT methylation present had longer survivals, average about 13 months. So some patients are even more frail than that, and coming back and forth for 3 weeks daily treatments is a little too much for them. And so we've looked at, well, can you condense the radiation down into 1 week, just given 5 treatments? And comparing that to the 3-week regimen, and actually found no difference in survival. Now, this trial was without chemotherapy, so this is radiation alone. So in some patients who it's just going to be sort of too burdensome for them, or they're deciding on some treatment but less treatment, this can be the right option. And then, as I mentioned earlier, we know that the patients who have that MGMT marker present tend to respond better to treatments, in particular the chemotherapy. So this trial, the NOAH 8 trial, looked at comparing radiation alone for 6 weeks, which now we probably wouldn't use that arm. We'd probably do a shorter course of radiation, versus temozolomide alone. And what they found is in all comers, there's really no difference. But in patients with that MGMT methylation present, with temozolomide alone, their survival was about 18 months. So in those particular patients, if they're really just not wanting to get radiation, chemotherapy alone can be a reasonable option for them. So summarizing kind of the current standard of care, maximal safe resection, followed by radiation and chemotherapy. Typically, that's going to be for 6 weeks, and then followed by the maintenance chemotherapy in tumor treating fields. I always try to tailor the treatment recommendation to the patient and take the whole patient into account rather than just the tumor. So I will also discuss sort of shorter regimens with them. And also I think it's important for some people to acknowledge that hospice is a reasonable option depending on their functional status. So what happens when the tumor comes back? I like to think of it as we kind of go through the process from the beginning again. So we have that multidisciplinary discussion. We're usually asking the first question is this a tumor that can be safely resected, or will resection benefit because of mass effect? Are there alternative systemic therapies that it may respond to? And then my area is considerations for reirradiation. So in typically we sort of say if something recurs within 6 months of getting the radiation, it's probably not going to respond to additional radiation. So I usually don't recommend it in that sense. Then we look at factors like, is it recurring where they had the prior radiation, or is it out of field now? Is it a large recurrence or small recurrence? And then is it in a part of the brain where we've already given some radiation and additional just would not be safe, such as your brainstem or the optic nerves? So the RTOG conducted a trial looking at Avastin bevacizumab plus or minus radiation. And so this was a much shorter course. It was 35 gray and 10 fractions, but the majority of these were to the initial site where the tumor was initially treated. And did not find a difference in terms of overall survival, but there was a difference in progression-free survival. So on average, it was about doubled with the addition of radiation to Avastin. So in patients who could qualify for reirradiation, I usually look at that as the sort of benefit, is that if we help improve your progression-free survival, we're helping to maintain your independence for as long as possible, even if that's ultimately not going to help you to live longer. So this is a case I had. This was a patient who had that MGMT marker present, although I put a little asterisk there because at his initial surgery, the path came back as negative, so that's what we were thinking in terms of whether that MGMT marker was there or not. He had a gross total resection at initial diagnosis, got the standard treatment with radiation and chemotherapy, and then 3 years later, he developed a recurrence right along the cavity. So right then we were thinking that initial path may not have been so accurate. He underwent an additional gross total resection of the recurrence. This time the path did show that marker present, which was what we would suspect. And so we treated that with the Avastin and with radiation 35 and 10 fractions. And so you can see that this is a small area. It was well after his prior radiation, and it's far away from any sensitive structure. So this is really sort of the ideal situation for that. And so now I think he's about 9 months out and still has not recurred. So he's doing well. All right. And I think we're saving questions till the end, right? Yeah.